Let's see. Hello, everyone. Welcome back to VMR, like 10 million at this point. I'm so excited to be here with my brother and partner in crime. And yeah, we're so thankful and grateful to the CP Solvers community to be able to discuss together. And Alec and I have been discussing many things about life for, since we were in the womb. But in medicine, we often call each other and talk with each other on our commutes and about medicine, and to be able to do it and to learn and to grow with you all. It's really a privilege and a highlight for us. So it's really just a pleasure to be here. And thanks so much for everybody for coming and contributing. And so whenever we're ready, we can go ahead and get started.
Awesome. And I just want to go ahead and thank ahead of time. Patricia will be giving us the teaching points and Vinicius will be scribing. So, and our own Mukund will be presenting a case. So really looking forward to, growing in this space, chatting with Austin more formally. I guess whenever we can share the screen, we can go ahead and get started.
All right, sounds good. Hey, everybody. Nice to see you all. I have a good case for you today. I hope you enjoy it. The chief concern is, are we ready? Sorry. Having some tech issues.
Yeah, you can go ahead.
Awesome.
Okay, great. So the chief concern is fevers and abdominal pain. We'll give you a bit of the HPI. So this is an 80-year-old woman. She is otherwise healthy. The episode of nausea, vomiting, and abdominal pain started 4 weeks ago and lasted about 1 to 2 days. Similar episodes have occurred over the last 3 years. They were thought to be GERD and they were controlled with lansoprazole. This time the lansoprazole helped with the abdominal pain, but soon thereafter, and this was all 4 weeks ago, the patient developed fevers that began to persist, mostly at night, improving with ibuprofen, but recurring every other day. She also endorses progressive generalized weakness and fatigue over the last 3 weeks leading up to her presentation. She denies blood per orum, blood per rectum, and weight loss. There's no constipation, no diarrhea, but she does endorse night sweats over the last few days. She got labs drawn at her PCP's office yesterday and was told to come urgently to the emergency department. That's the end of the first aliquot.
Okay, wow. Very interesting. Thanks for a great start, Mukund. Austin, I'll go ahead and just give it a first shot, and then I'd love to layer in your thoughts on top of that. But, we have an 80-year-old woman, otherwise healthy, and otherwise healthy meaning that this truly is a healthy 80-year-old, or this 80-year-old hasn't really had a lot of interactions with healthcare to diagnose certain problems. So I'm just keeping that in the back of my mind about what exactly that means. But here we have a, febrile abdominal syndrome. And I think with abdominal pain, I always like to use the CP Solvers mnemonic for things we don't want to miss, was the BIPO mnemonic. So, vascular inflammation, perforation, obstruction, and just keeping many of those things in the back of my mind. But I think something that strikes me here is what I'm calling the time course of this illness. Is this an acute intermittent syndrome that just happened many times over the last few years and happens to be worse this time? Or is this a more acute on chronic progressive illness? And I think as we get more history and we get into our physical exam, we'll be able to elicit that a little bit further. But it seems like there's certainly is an inflammatory component to this with the fevers, with the night sweats, but the pain seems to be perhaps not as severe as I was initially anticipating. So I think the fact that there's no change in bowel habits either means that they're subtle changes, or perhaps the patient lives with diarrhea and hasn't really thought all that much of it. Or there's something else that we're missing, and I don't want to miss anything referred from the cardiac system or anything below in the GU organs, or the renal pelvis, for example. But I think it's hard to know exactly what to build on top of here, besides missing the no miss things, and just recognizing this is an acute inflammatory syndrome. But I'm fascinated to see what these abnormal labs are that prompted an urgent visit to the ER, because I think that would really help us reframe. But besides that, Austin, I don't know if I have much to say right now, but I would love to hear what you're thinking.
Yeah, no, I think that's a brilliant start. And I think it's the only thing I can really layer in on is just trying to focus on the aspects that are a little bit different. So what's different about this time compared to the previous times? And really it's the signal of inflammation in measured fevers, night sweats, sort of the malaise or asthenia, which will sort of get to clarify if there's true weakness or if this really represents asthenia. Um, as we get more into the history. And so really we're in the bucket of inflammation, and then we're in the bucket of subacute or maybe even lending into chronic inflammation. And so when we add abdominal pain to that, how can we make progress? So if I go through the buckets of inflammation with our favorite IMA mnemonic, or infection, which, infection could definitely be at play, but just given the time course, we're starting to get into more atypia. The patient is relatively immunosuppressed just based off of their age, but we'll learn more and to see if there's any chronic conditions, though it seems like this is a healthy person or with the caveats that you outlined. Malignancy, which is definitely a consideration in this scenario, autoimmune drugs and endocrinopathy. So if I think we take everything at face value and say, this is a woman with no significant medical history that has a subacute to chronic inflammatory abdominal syndrome, what bucket does that seem to map in? And I think really the malignancy seems to fit best from a base rate or statistical standpoint. And I'll be curious to see. Of course, we wouldn't want to miss infection, and infection is so common that it can present in so many different ways. So of course, we'll be tracking that, and hopefully for the patient, that's what it turns out to be. But I think already from the get-go, I'm concerned that we're in a space that this patient could have a very morbid diagnosis. Just lastly, to talk about the GERD or PPI trial, as a primary care doctor, I was actually giving a lecture on how to teach clinical reasoning, which is only possible because I was a part of the clinical problem solvers. But I was talking about illness scripts and how, depending on where you are in your learning career thus far, your illness script for conditions is different. So when I first learned about GERD, my illness script was just that someone that has basically burning pain in their chest after they eat. But I've seen GERD present as isolated nausea. I've seen it present as isolated cough. I've seen it as people gasping for air. I've seen it as nonspecific abdominal syndromes. I'm like, hey, I have no idea why this person's having this, but I'll throw a PPI at it just in case it is atypical. And so, is it relevant to this person's presentation, or is it just signal, just a noise in the background? Hard to know, hard to make progress on that. I would say it's just so common. And things can present atypically that maybe this was GERD and maybe it could have been signaled to some sort of obstructive lesion that we'll learn more about. But I think probably it may end up being something that's just a fine detail that we're going to end up not being relevant to the presentation. But really excited to learn more from Mukund, and take it away.
Yeah, that sounds good. I appreciate your discussion. I think we were in the same situation initially with this being, to an extent, a very non-specific history, and with the patient's immigration history, which I'll get to in a second, also unsure how much she had engaged with care in the previous years or even decades. But I'll give you the next aliquot, which will be this bottom left quadrant, and then the physical exam as well. So for past medical history, she does have a PCP in Thailand, where she's from, and truly is otherwise quite healthy. Has some hypertension, some hyperlipidemia, some mild osteoporosis, and this GERD that we've mentioned. As far as meds, she's on mirtazapine, mostly as an appetite stimulant, simvastatin, and lansoprazole. She doesn't have relevant family history. As far as social history, she moved here from Southeast Asia about 6 months ago. Doesn't smoke, doesn't drink, has no allergies. Moving on to the physical exam. Her vitals are as follows: 39.2 degrees Celsius for temperature, 115 beats per minute heart rate, blood pressure 124/67, and respiratory rate 21. Generally, she's very thin, elderly lady. Temporal and thenar wasting are seen. Sclera are non-icteric, conjunctiva are normal. She's tachycardic. She has a soft systolic murmur, maybe a 2 out of 6 at best. Lungs are clear to auscultation. Her abdomen is soft, non-distended, and honestly non-tender to our exam too. No other findings on the physical exam are relevant. And I'll just give you the lab value that brought her into the hospital too, just to be authentic to the way we experienced this case. She had a CBC drawn at her PCP office with a white blood cell count of 28. That's the end of this aliquot.
Okay, very interesting. And will you be revealing the differential of the white count later on, or it can be revealed now, or what's
I'll
that?
reveal it soon.
Okay, wonderful, wonderful. So we'll try to make progress with how things are going. Okay, yes. So we learned about this patient, and she seems to be from originally from Southeast Asia. How long has she been in the States? I missed that.
6 months.
6 months. Okay. All right. So relatively, recently immigrated to the United States or visiting the United States, but seems to be from the care that she was able to access, healthy, hypertension, not on any medications. It seems like hyperlipidemia, and some osteoporosis. For an 80-year-old, these are all relatively common conditions. So I'm not really putting too much stock into them right now, and won't invest a lot of cognitive energy, but we'll see in the future if that needs to change. The medications, I think, are all as expected based off the history. The mirtazapine is very commonly used for appetite stimulation or for depression, and more recently for appetite stimulation, especially in patients with cancer. That's sort of fallen out of favor in favor of actually sort of the atypical antipsychotics, but is still commonly used. So it doesn't really add too much to me. As far as the vital signs, the patient is febrile, so we confirm exactly what the patient was saying, that they're inflamed, and so we'll start to make progress on that. The heart rate, a little bit tachycardic, so would need to be vigilant about the possibility of sepsis for sure, and I'll probably treat empirically for that. The blood pressure, I think it would be difficult to get records from Thailand, but to understand if what's the patient's baseline blood pressure, given that she has hypertension and she's not on treatment, is this low for her? Or is this kind of where she lives and she has white coat hypertension or something like that? And the respiratory rate is mildly increased. So maybe again, in the presence of fever is just a sort of a manifestation of her being systemically ill. But I think the exam is really what's most powerful, along with the white blood cell count. So I'll defer to Alec on that and sort of chime in if there's anything else. But that's my general takeaway so far.
No, awesome. That was excellent. I love your sort of lens as a PCP and things that you see in patients of that are a little bit older and seeking care. And yeah, very struck by the sort of degree of the fever that the patient has. Confirms the inflammation, but that's very high. And I think what the exam really helps us with, particularly, is the time course, because she's a thin elderly lady with temporal and thenar wasting. So my initial theory could have this just been acute intermittent, kind of falls to the backside, and this seems to be more sort of a subacute to chronic progressive syndrome, maybe with acute flares. And so the ictera or anecteric, which hard to know exactly how to make progress of, but with the absence of abdominal pain, and no other sort of clear hematologic signature besides a white count yet. We'll see if that bears fruit or if that was just something that was mixed. The conjunctival are normal, so it doesn't necessarily suggest anemia, but at the same time, it's not sensitive enough to exclude it. The systolic murmur are 2 out of 6. Systolic murmurs in people that are 80 are exceedingly common, so it's hard to know how much cognitive energy to place into that. Could this be endocarditis? Could this just be a flow murmur? Could they just have some aortic sclerosis? It's hard to know, but I think in the fever, the sort of infectious endocarditis or, culture negative endocarditis or, subacute endocarditis are things that we can consider. I think something that was really striking that I wasn't expecting is that the patient really came in with a primary complaint of abdominal pain and has no abdominal pain on exam, right? So either they received medications to tamper that down, and we're meeting them at a time where the medicines were effective, they're no longer going to have abdominal pain, and we'll have to go back and reassess when they do. Or this is something that's intermittent, that's not triggered right now. Or perhaps the pain is referred from something else. And so I think taking some iterative history about if there are triggers for any of this pain, the quality of the pain, the exact location. And one of my favorite things to do is when people say that they have pain is to ask them to use one finger at the point where it hurts the most, because sometimes I can feel I can make progress there. So if they tell me, oh, I have chest pain, and then, they point to their shoulder, right? That's a lot different if they point right over their heart, right? And it's the same thing with abdominal pain sometimes. And then, on exam, we didn't get any other signs of, cardiac issues. There wasn't any JVD, there wasn't any edema, there wasn't any rash. We didn't have any known organomegaly, there wasn't any lymphadenopathy, and either of those are things we'll find out in the end, or those are things that were excluded because they weren't present. And I think from the white blood cell count, the patient is very, very inflamed, and didn't necessarily need the white count to confirm that, but it just further supports that hypothesis. And love how Austin was sort of asking eagerly for the differential. I was doing the same, and I think we'll get to see what type of inflammation this is, funky or not, to use Robbie's term, and I think we can build around that. Is this neutrophil predominant and more suggestive of a pyogenic infection or just sort of a cortisol response? Is there lymphocytosis, eosinophilia? Are all these white cells actually blasts? And could this be leukemia? What exactly else is going on? And I think the company that the white count keeps will also be very helpful to see if this is more pancytopenia or something else. I think as far as what I would be doing now from a management perspective, yeah, I mean, we have a febrile syndrome. We don't have a lot of past history. There seems to be an acute component to the fever. The best that we can tell from the history, I would be treating as this is an infection, probably as an abdominal source. So I'd be giving fluids, would be giving the antibiotics. I would more than likely be considering some advanced imaging in this instance. Because of the patient's, recent immigration here to the United States, I think it would be helpful to ask about vaccinations if they had any sort of examinations prior to coming to the United States, if they were tested or ever treated for TB in the past, and I would have to look up, particularly in the region of Southeast Asia that she's from, in Thailand, what other infections might be endemic that we could be thinking about, melioidosis or sort of other things. But yeah, I think the disconnect between her presenting complaint and the physical exam findings are unique, but we could have just caught her in a good moment in time, or this is something that the tube of truth will tell us. So yeah, Austin, I'm not sure beyond that how much more I have to add, but I'd love to hear what you're thinking as well. Oh, and then blood cultures, of course. Don't want to miss that.
No, I think that was brilliant. And I've not explicitly talked about endocarditis many times on these platforms, so I'm glad that you brought it up to begin with. You also brought up something really interesting about the exam. We didn't hear that the patient was like writhing in pain. She appeared cachectic somewhat, but relatively comfortable appearing. But it did invoke in my mind the possibility of like pain out of proportion to exam. So I don't think we got that signature, but that could help lead us, down a path diagnostically potentially. But we'll see where things go. I think I would like to challenge ourselves right now and predict what the differential on the CBC is going to be. And so I'm going to be, I honestly don't know, but I'm going to try to just analogically reason through this about the time course. And again, it's all about making sure the time course is correct, but I'm going to assume that this is chronic just based off everything that you already outlined. And so what will be, what we will find on the differential. So I'm going to break it down really into neutrophilic, monocytic, lymphocytic, or eosinophilic, and go from there. Neutrophilic, which again, I'm evoking more of a bacterial, fungal infection potentially. Again, if we're to believe the time course and this patient presented to the clinic, if I think through my experience in working in the clinic, I have never seen a patient come in with a white count of 28. That's incredibly high. Even in the hospital, it's been a while since I worked in the hospital, but Alec, you can correct me if I'm wrong, but seeing a white count of 28 is going that high. I'm starting to wonder if it's hitting that threshold where I need to worry about the more severe types of pyogenic infections like C. diff or missed abscess or something like that. So I think the possibility of a sort of typical infection causing this is relatively low, unless the neutrophils are neoplastic in some way, or there's some sort of what's the term I'm thinking of? There's like a perineoplastic phenomenon happening, like from where the neutrophils are being stimulated to be released. But I think I'm feeling less likely on that. What about a monocytic infection? So again, we're invoking the possibility of, a blood dyscrasia of some kind. Could those present with abdominal pain in the form of like splenomegaly or something that we can pick up on our exam? Potentially, it could also make the patient relatively immunosuppressed. So I'm open to that possibility. As far as lymphocytes, yeah, I mean, definitely, definitely a possibility here. If we're invoking the possibility of overlap of leukemia, lymphoma, definitely a consideration. And then lastly, eosinophils. Eosinophils can infiltrate and cause symptoms in any organ. So it's a possibility. I would say that the absence of other symptoms like respiratory symptoms, rash, just leaning into the base rate of what causes eosinophilia, which is basically atopy and allergic causes, which the patient being from Southeast Asia, there's definitely infections to consider for sure. But I think that the time course, again, maybe speaks against it, unless there was like the patient received a course of prednisone or something within the last month or so. So yeah, I guess I'm leaning more into the middle two buckets. If I had to commit, I'm just gonna, and I'm fine to be wrong here and excited to learn more, but I'm gonna go into the monocytic bucket, maybe neutrophilic bucket, so we'll just fall into that line of cells as far as their differentiation pathway. But Alec, what are your thoughts?
Well, I love that you're really challenging yourself and by proxy me. But I think for me, I think those are all very important considerations. But I'm just gonna sort of keep it simple and just go by base rate. Whether this is infection, whether it's a response to inflammation, whether it's just a hypercortisol response and the setting of the fever. Like I'm just gonna go with neutrophilia because a lot of those diagnoses, like dying bowel, a rip-roaring pathogenic infection, those are things that we don't want to miss. And so while the other things are also very concerning, I think I'm just going to say that neutrophilia is probably the most common differential I see. And for now, until I have a little bit more information about some of the other labs and perhaps some of the imaging, I'm not sure if I'm quite willing to commit to the others yet, especially because maybe Mukund can clarify this for us, but I'm wondering if in the prior episodes of pain she had in the preceding years, if fever was a component of that, or the fever is something more acute. And I think that might change things. But yeah, Mukund, I'd love to learn more about how things progressed.
Yeah, absolutely. I'm so grateful that both of you have picked up on this kind of tension between what appears to be a subacute to chronic history, a shockingly benign physical exam, and very concerning vitals and white blood cell count. I think it was hard for us to put this picture together too, and I was hoping that that kind of tension in those combinations of symptoms could come through in a presentation. So thanks to your clinical acumen, of course, we've had that discussion. I'm really grateful for that. She had not had episodes of fever before this presentation, but prior episodes of abdominal pain felt similar. So Alec was right, is a strongly neutrophilic differential on the CBC. And in fact, it peaked at 34 for us. I'll give you the rest of the labs for this aliquot too. Hemoglobin of 11.3 with an MCV of 91. Platelets of 575. Sodium of 134. Potassium of 5.7. Chloride of 96. Bicarb of 30. BUN and creatinine normal. I'll give you a VBG too, that was done in the emergency department. A pH of 7.48, PCO2 of 42, CO2 of 32, and a bicarb of 31.3. More labs. Liver function, AST of 147, ALT of 48, both of which are high. Alk Phos of 219. GGT of 78, albumin 3.0, which is low, total bili of 1.1, which is normal, and a direct bilirubin of 0.8, which is a little high. We also got a lipase, which was normal. 2 blood cultures were drawn and are pending, and he was started empirically on vancomycin and ceftriaxone. I know you all want the imaging, and it's coming soon, but that's the aliquot.
Okay, excellent. Thanks so much, Mukund. And then just to clarify, that GGT, is that elevated for your lab or is that normal? I didn't hear you there. Elevated? Okay. Okay, excellent. So yeah, I'll go ahead and sort of give my breakdown of the labs here. So I think somehow ended up on a different case, I think. I'm not sure if we could go back to the prior whiteboard if that's possible.
This was my case from yesterday.
Okay, well, I
Yeah,
didn't get to be there, but I'm reading the board now, and it looks like it was an excellent case. So sorry I missed it. Thank you very much. So I think the anemia not unexpected for the degree of inflammation, and the thrombocytosis just points to inflammation as well, probably more like sort of subacute to chronic. So I think that's supportive there. I was wondering if they may have more significant cytopenias that might point to the bone marrow, but it seems like probably the bone marrow is more of a bystander here. As far as getting into the BMP, I'm very struck by one, the hyperkalemia, and two, the degree of alkalosis here. We didn't get a history of significant vomiting. And then whenever I see alkalosis like that, I always think about the possibility of hyperaldosteronism, but the potassium is not low, it's high. And the creatinine is normal, reportedly. I don't know what normal is for her. It seems like we didn't get a BMI, but I imagine if she was cachectic, she was quite a small woman, and the creatinine can often be an overestimate, the GFR. So perhaps she may have some CKD that has been previously undiagnosed, or this is truly unrelated. So I think I would be wondering if that, with the degree of leukocytosis that's in the peripheral blood, whether that potassium is a little bit hemolyzed or falsely elevated. So I'd be clarifying with the lab there to be sure that that's correct. And then, the VBG just confirms that this is indeed an alkalosis, and it doesn't seem to be primarily driven by a respiratory component. This is a metabolic alkalosis. So I'm sort of wondering, we don't get a sense of diarrhea. It seems like the patient's taking a lot of bicarb. What else could be driving this? And I'll have to admit, beyond those kind of things, my schema for metabolic alkalosis is fairly weak. So Austin, I'll be asking for your help with some of that. And then, some mild elevations in the AST and ALT with an elevated alkaline phosphatase, which is corroborated to likely be hepatic by the GGT. So, from a patient from an endemic country for hepatitis B, certainly don't want to miss that. I think with an acute febrile syndrome with abdominal component, definitely don't want to miss any of the other infectious hepatitis as well. And then, the AST is more predominantly elevated than the ALT, so I don't want to miss hemolysis. We've had multiple cases on VMR where hemolysis and the hemoglobin is stable. Seems like we're getting less of a flavor of that, but I definitely want to, think about that, consider if we need to get a smear, and we probably will as well with the degree of leukocytosis. And then also would be considering, is that AST really from the liver, or could that be from muscle? And we could get a CK to sort of recognize that as well. The bility seems to be predominantly direct, which maybe would point away from some extravascular hemolysis from what we were thinking about before. I agree with the empiric antibiotics. I am looking very forward much to see the imaging, but I think Austin at this point, patient's very inflamed. We have a very significant neutrophilic leukocytosis. Based off morbidity, very concerned about an infection. Which type of infection is a little bit unclear, but I would be trying to investigate that a little bit further. And then I'm very struck by the degree of the metabolic alkalosis, and I don't really have a great explanation as to why the patient has that. If the potassium is actually low and that 5.7 is falsely elevated, maybe we could evoke some hyperaldosteronism, but beyond that, I'm a little bit stuck. And the liver chemistry tests are a bit elevated, but mildly so. And I think the imaging will help us, characterize things further. And because you and I have both missed this and asked about it earlier, I think the immune status of the patient is very, very important to distinguish, and we should get an HIV test to sort of the risk stratify. And then just because this patient is from an endemic country and we're not exactly sure what sort of screening they may have had done, unless Mukund will share that with us later, I think just getting a screening chest x-ray just to be sure there isn't something there that would potentially help us build a differential if there's a pulmonary component to this. And just because TB can literally do anything, and she's from an endemic country, that's not something I would want to miss either. But I would love to hear, Austin, how you're layering this in and what you're thinking of the metabolic alkalosis, because I'll be honest, I'm struggling with this.
No, yeah, really nice breakdown of the labs. And yeah, I think in regards to the metabolic alkalosis, if I just break it down into the buckets that I think about, so I kind of like to go by base rate. What's the most common things that we see? So vomiting. So maybe the patient's vomiting is a little bit more pronounced than we were able to elicit from the history. I think the other one would just be volume contractions, or like a chloride depletion alkalosis. I don't recall The chloride was 96, so it was relatively low. So maybe the patient is not eating or drinking very much. They're vomiting enough to where they're reaching a chloride depleted state, and that's manifesting in what turns out to be a relatively mild metabolic alkalosis. So is it something we really need to put a lot of cognitive energy into? I'm not sure, to be honest. So otherwise, you're right. We're sort of in like, is there aldo? Is it inappropriate or appropriate? Are there some rare issues within the tubules of the kidney, some of these genetic disorders that can cause metabolic alkalosis? I don't think that we're there. I do really like your point about the creatinine. So it'd be nice to know if it was like, I'm guessing this person's creatinine probably would be like 0.5 if it was normal. So if it's around 1, then the patient has significant CKD, and the combination of CKD and alkalosis is definitely an interesting combination, and one that maybe there's, as you said, an ingestion standpoint that we'd have to consider. But yeah, I'm not sure exactly how to make progress with that, to be honest. If I take the sum of the labs in total and say, hey, we have a prominent neutrophilic leukocytosis, and what seems to be some signal of inflammation in the liver, or something happening in the hepatobiliary system, then to me, that's the center of gravity, and that's what we have to explore. We already sort of discussed why we are concerned about this patient and the possibility of malignancy, but I think this patient needs imaging to further reconcile exactly what's happening, because really I've not been able to localize much more beyond these labs. If I think of what can cause nonspecific abdominal syndrome with fever, certainly hepatitis is a reasonable consideration. But again, it all comes back to the time course. And, maybe we'll find that she does have some sort of chronic illness, and there was a second hit that happened. And now those things are coming to light. But I think this patient is in a CTPenic state, and we will have to rectify that by getting the imaging. What else? Again, Alec, I need to lean on you, because I really haven't encountered this in some time, but a white count of 34, like, tell me the last time you saw a white count of 34.
Last week when I was
Last week,
on.
okay. So maybe am I putting too much energy into that? I mean, it seems like so profound, and I feel like that could help us make a little bit of progress, but it might just be a knowledge gap for me.
No, I think, and I was being a little bit facetious. I mean, I saw a white count of 150 in a patient that had acute leukemia, right? So for patients that I've recently had with pyogenic infections, like I've seen 22, 24. But when I start getting north of 20, I definitely start worrying about things that you had mentioned, that where you get a leukomoid reaction, either from very bad pyogenic infection, abscesses that have not been drained, C. diff comes to mind, gram-negative bacteremia, and sort of other things related to that. So it's very high and it's very concerning. And then I think because you sort of so eloquently talked about how really the only sort of signal of inflammation in an abdominal organ we have right now is the liver. I love your thoughts about the hepatitis, and then I just would be remiss not to mention cholangitis. I know the bilirubin is not elevated, but yet, and that would be something that we would not want to miss. It could potentially be very life-threatening to the patient. And then as far as thinking about management as well, as far as antibiotics, I think vancomycin are great. Again, I'm still struck by the disconnect between her presenting complaint and then like her benign exam. But if we are thinking that if she does have an infection, number one, and we think it's pyogenic, and we think there's an abdominal component, would there be a reason to be doing anaerobic coverage here as well? And I think I would probably lean towards yes, but I think we would have to see how the clinical picture unfolds. And I like how I think you explained your reasoning about how perhaps this is just the alkalosis is just a reflection of some volume depletion that might get a little bit better. And we can track that as signal or noise, depending on how they do after they get resuscitated and how the labs trend out. But before we pass it back to Mukund, did you have any other thoughts at all?
No, I just love this conversation because it's really bringing in the tension of the time course, right? If we believe that patient's time course that they presented to us, then I mean, I really am favoring a pyogenic infection for sure. If we're really leaning into that this is more chronic, then again, we would not change our management acutely, because we would not want to miss an infection because it'd be so morbid. But it's really lowering that possibility in my mind. And so I'm inclined to trust the objective findings a little bit more, just with the challenges of obtaining a history, especially in a patient, which I'm not sure if this patient speaks English or not, or if it's their first language, but obtaining a accurate history from a patient in which, it's not their first language in a new environment, because the way healthcare is practiced is dramatically different in different parts of the world. So I would probably be leaning in more to the objective findings. Again, I wouldn't not treat for a bacterial infection, but this really makes me worry more about something indolent, and in particular a malignancy. If we just sort of run the list of things that causes a reactive thrombocytosis, obviously we can think about a spleen issue, iron deficiency being the sort of base rate most common, but a seronegative autoimmune disease, which at 80 is possible but less likely. A Subacute to chronic infection, which we've invoked and could be an atypical infection for sure, but then it's solid cancers, right? I think that's the space that we're in, and so yeah, really, it just is just such a beautiful clinical reasoning point about the tension of the time course. And as a medical student, like I feel like I did not understand that time course was queen. Like I truly did not appreciate the gravity of the time course when you're interacting with patients and seeing patients, and this comes up over and over and over again. So I think our focus and our efforts to try to clarify exactly what the time course is a really good way to invest our cognitive energy in this artificial exercise. But yeah, I'm really excited to see what Mukund's team was thinking, and where they went next.
Yeah, this is great, everybody. I am really happy that we had such a good discussion about the metabolic alkalosis, which was also confusing to us at first. And, before we went down the tree for workup with the urine chloride and whatnot, just went back and talked to the patient, and turns out she was taking a lot of Tums. So we ended up chalking this up to a milk alkali type of situation. And I didn't give you the calcium because I was mean and wanted some more discussion, but the calcium was a little high, and with the low albumin, it actually corrected to be appropriately elevated for a milk alkali type picture. The other great teaching point from the chat is that this person with an intra-abdominal source of possible infection, there is an anaerobic coverage, and indeed, when she was admitted to medicine, she was transitioned to ceftriaxone and metronidazole. But you have always wanted the CT, and I have been giving you all CT Phoenix cases over the last few days, withholding them till the last minute. So the next aliquot is actually just going to be the CT and its findings. Vinicius, if I can share my screen, we'll have you go through the interpretation of 2 sections from the CT, and then I'll give you the formal read.
All right, I'll stop sharing. Yeah, so how can I stop sharing?
Can you all see this?
Not yet, Mukund.
Yeah, how can I stop sharing? Does anyone know?
Mukund, if he's a co-host, should be able to just take over the screen.
Yeah, I thought that should have been okay.
Oh,
let me try again.
We're seeing your face in full view, which is wonderful.
Try this.
It's loading, it looks like. Okay.
Great, we can see it.
Seeing a cut.
Yeah, so what do we see?
All right, Alec, do you want to go, or you want me to try to give my general interpretation?
Yeah, I mean, why don't you go ahead and then I can layer in after that.
Okay, so yeah, we're seeing sort of a cross section of the abdomen here. We're at the level of the spleen and the liver in its full glory. I think the patient, just generally speaking, is thin. We're not seeing a lot of extra abdominal fat. If I sort of work my way out to in without getting too excited at the main findings, then not seeing anything grossly obvious with the bones here. or the spine. It seems to be okay. The musculature seems to be okay. Not really seeing any edema. Working our way to the intra-abdominal organs. I think we're seeing a little piece of the stomach here, kind of in the middle of the screen. It looks like maybe some prominent vasculature below that. I don't know if that speaks to varices or not. I guess we'll learn. Next to it is the in sort of anterior and to the patient's left of their vertebra is the aorta, which seems to be calcified. And then working our way to the spleen I see as well. It doesn't look terribly large to me, but if we get more cuts, we might be able to make more progress than that. And then the liver, we're definitely seeing a lot of some hypodensities within the liver, and then some prominent, with the way that it's shaped, it looks to be along maybe a vascular line or the biliary tract, but it's hard for me to really, I'm not confident on that, but I do see multiple hypodensities, and then centrally there is sort of like almost like a S, a cartoon S-shaped hypodensity that's prominent in the middle. But those are the things that stuck out to me. What about you, Alec?
No, I agree. I love that. And yeah, I don't know if the below the stomach, if those are dilated veins. And then certainly there are some peripheral hypodensities throughout the liver. And then the more central hypodensity, yeah, it's hard for me to say if that's primarily like portal system dilatation, or if that's just a weird shaped abscess, or if that is related to the biliary tree as well. But I think with the, I think you astutely noted that based off the labs that, the liver is probably the focus. And I think the CT just helps to confirm that. And I think, if the biliary tree was this dilated, then we would sort of be invoking more likely to have extrahepatic biliary obstruction, and really struck how the total bili was normal. So it could be we were just early in the course, or this actually doesn't represent biliary ductal dilatation and represents something else. But I think I could say that, those lesions there are, hypodense lesions in the periphery. And then I would love to know with the contrast, how they read these, were sort of enhancing or not, and whether we would invoke these as being abscesses or whether this was something different. But I'm not sure, Mukund, if you want us to look at the next one as well. But
yes, this is a slightly different cut.
Okay. So yeah, still seeing those ongoing sort of diffuse hypodensities throughout the liver. And there is air. And I guess I'm not exactly sure if the air begins where the liver ends, or if that's actually in the right, the left hepatic lobe, if that's actually intrahepatic air or not. And then the air further off to the patient's left, sort of versus our right of the screen, that gets sort of confusing, but it seems like that's probably bowel, or that's just the tip of the liver and the patient has some hepatomegaly. But without sort of scrolling up and down, it's a little bit hard for me to tell. But I think it just corroborates that there's something going on there, and that I would be interested to know what they read it as, and sort of what that dilatation was on the prior cut. But Austin, what are you thinking? And then lastly, there seems to be more sort of can really make out the veins or sort of the vasculature around the spleen there. And that's just not something that I typically see when I scroll through scans. And anytime I see, prominent vasculature in and around the portal vein, you definitely have to think about portal hypertension. And that these veins, they take time to form. So this speaks to more of a chronic process. So, I think this just maybe further supports that this has been something that's been brewing for a long time. But Austin, I'm not sure what you were thinking as well.
Yeah, no, really nice. And yeah, those little squigglies, I like to call them, look exactly like varices to me, but we'll start to learn more. And I lack confidence enough in saying that these are definitively splenic varices, but that has its own differential diagnosis, which you can say, yes, this is common things being common. The patient has unrecognized liver disease, and then had portal hypertension that led to varice formation and splenomegaly. The disconnect between thrombocytosis and splenomegaly, which I'm not sure if we're seeing splenomegaly here. We're just seeing varices. So again, I don't want to jump to conclusions that will kind of mess up my reasoning, but that's an interesting pivot point here. I think we take a step back and we say, hey, we see even more hypodense lesions in the liver. How does that influence our probability that this is an infectious? I'm not, I honestly don't know. I would say in my clinical experience, seeing this many lesions makes me invoke the possibility this is metastatic disease in the liver or a multifocal cancer as opposed to infection. But I'm happy to be wrong about the hypothesis. I just don't know for sure. The other thing to do for portal or for splenic varices is the possibility of a thrombus, in the portal system. So before the liver. So it's not so much that we're seeing portal hypertension in the venous system at the level of the liver, but closer towards the spleen. And that's where we're seeing the more prominent varices there. And then you have to invoke the possibility of, okay, why is there clot there? And, it's one of those sort of clots in weird places. And then, so we have to, again, invoke the possibility that this is cancer. Certainly you can have a reaction there that is related to infection. I had a patient that had a profound liver abscess syndrome and developed multiple clots in their abdomen, and so certainly it can be a product of local inflammation. But again, the time course is everything. The time course is everything here, and I think that's what we'll have to make progress on. So excited to get the formal read from an expert and make further progress.
Yeah, absolutely amazing discussion. The thing I wanted to point out here, and Austin, you were spot on, is this kind of chunky vessel that feeds the liver. This is actually the portal vein, and it is massively thrombosed to the point that you are actually seeing wall thickening of the portal vein kind of in the intrahepatic region of that portal vein. So just a pretty remarkable finding. And you all were right about those squiggly vessels, those are varices. This is not something that I still honestly can see, but if you talk to radiologists, they will also tell you that there is such a thing called cavernous transformation of the portal vein, which are these kind of serpiginous collaterals that form around a portal vein thrombus, and those were also present on that slice, such synchronicity. So I'll give you the formal read. Extensive high-density portal venous thrombus with wall thickening. Numerous clustered hypodensities centered about distal thrombosed portal vein in the liver parenchyma with surrounding contrast hypoenhancement. Prominent splenorenal portosystemic shunts. Dilated common bile duct measuring 1.4 centimeters with wall thickening and enhancement. Decompressed gallbladder with dependent debris. So that's this aliquot, and I have one more before the diagnosis.
Okay. And then one more aliquot of information, or the next one will reveal it, Mukund?
Well, one more aliquot of information. How about that?
Okay. Yeah, so I mean, just a massive portal vein thrombosis with sort of chronic sequelae of that is sort of how I'm reasoning this together. I didn't catch everything about the hypodensity, so I don't know, because the portal vein supplies about 70% of the blood to the liver, and because it has two blood supplies, typically a blockage isn't necessarily going to lead to ischemia, but in certain clinical situations that can definitely happen. And could these densities be infarct? I guess in theory that's possible. I don't know if like some pieces of clot could have broken off and propagated and then caused local infarcts, and then those became abscesses, or those are just hypodensities there. But I didn't hear, and correct me if I'm wrong, Mukund or Austin, but they didn't comment on cirrhosis. It seems just to be portal vein thrombosis in the absence of cirrhosis.
That's right.
Which is
aside from
okay.
the hypodensities, the parenchyma was normal.
Okay, very interesting. So I'm sort of having to build about what's the most common cause of portal hypertension with people without cirrhosis. And so the portal hypertension could just be from the portal vein thrombus, but then we have to ask ourselves what caused a portal vein thrombus in the first place. Did she have underlying sort of non-cirrhotic portal hypertension that just sort of progressed and then she got clot? Or is there something else in her abdomen that's going on that could be leading to this? So the most common cause of non-cirrhotic portal hypertension worldwide, I believe, is schistosomiasis. That, I guess she's probably from an endemic country. I don't know enough about Thailand to know if that's there. But the fact that the biliary tree is also dilated I mean, she has her gallbladder, so we can't invoke a reservoir effect. So is there something, there be something going on in her pancreas that was missed that led to hyperinflammation in her abdomen, which led to a portal-vein thrombus, which led to hepatic metastases, or which those hypodensities could be, like Austin sort of astutely mentioned, or could this be metastatic colon cancer or something else? Because I'm not sure how up to date she is on her age-related cancer screening. But I'm still sort of struggling. I think we can feel fairly confident with the time course now. This is probably more chronic or subacute to chronic progressive. And why she's acutely febrile seems to be probably an acute complication related to the sequelae of this, either superinfection of these lesions, or potentially her malignancy became bad enough that this became positive if she does indeed have malignancy. So I think the thing that and then I guess another thing that I would want to be thinking about as well is that hepatitis B is very common worldwide, and it's one of those that can cause HCC without developing cirrhosis beforehand. And any sort of inflammation in the liver can also predispose you to developing a portal-vein thrombus as well. But I don't necessarily think about it causing bile duct dilatation as well. I guess unless the obstruction is intrahepatic, but then you don't get that much dilatation of the CVD. So how I'm layering that is a little bit unclear to me. And then it seems like I don't really understand what the underlying trigger for all this is, and that the acute fever I'm still going to blame on infection because that's the most morbid. And some of these features, and I would love to know radiographically if they thought that these were representative of abscesses, were these representative of metastases, were these representative of infarcts, and sometimes a radiologist can be really helpful in piecing those things apart. But I think beyond really investigating, like, hey, do we see anything in her pancreas? Do we see anything going on, in her distal intestine, or just in her intestines? Like, is there focal inflammation in the cecum, or in the sigmoid? And those are things that we may need to investigate further with colonoscopy, for example. But I think as far as what to do from here, I think I'd still be waiting for a lot of my infectious studies. We just still don't know her HIV status. We still don't know what the sort of, viral hepatitides are. And then, whether or not it would be helpful to do additional imaging on top of this with an MRCP potentially to investigate the common bile duct a little bit further. But that's something that we could potentially consider. And yeah, I think I'd just really be going down to radiology in this situation and be like, hey, these hypodensities, do you think these are infarcts? Do you think these are abscesses? Do you think these are Mets? Like, what do you think these are? Because I think, it could just all be sequela from this big thrombus, or there could be multiple different things going on. But I think what we can say is that this patient has had portal hypertension for some time, because she's had the time to develop the splenorenal shunt, time to develop all these splenic varices. And now we need to figure out what triggered all this, and is the portal hypertension a secondary effect of the clot, or was this just made worse by the clot and there was something else that was driving portal hypertension in the first place, and what exactly that is? And I still think that we're definitely in the sort of, there probably is an acute infectious bucket, but because of the subacute to chronic tail of this, I'm really more leaning into potential malignancy. Autoimmune disease seems to fit a little bit less, but Austin, I'd love to know what you're thinking here.
No, I mean, I couldn't possibly add more to that discussion. I would say that I think my real challenge here is, like, where would I go from here in real life? Like, how would I make more progress about what to do? And you kind of outlined a few things. I mean, I would definitely treat empirically, wait on the cultures and see what hits. And if something hit, then, I think we potentially would have an answer from there. But right now, I mean, for the reasons we already outlined, I'm concerned about malignancy. We could talk about the drainage patterns and localization. But depending on, what type of malignancy we're invoking, whether this is solid organ or this is, blood cancer related, I would say that really I'm more in the solid cancer space if we're invoking the possibility of malignancy. And so I would probably go looking for a cancer somewhere else. Like, I would definitely CT this person's chest and see if we find anything. And I would honestly go after that. If we don't find anything and the infectious evaluation is unrevealing, then, I think we have to go after, if it's possible, one of those lesions in the liver to try to make progress about what to do. But it's just a diagnostic challenge for me. I'd definitely be leaning on my consultants. But I'm definitely in a space where I'm concerned. We're going to treat for infection for morbidity, but concerned still about malignancy. It would be exploring every path possible to make sure that we didn't miss that either. And then, yeah, I think I've seen it I try not to look at the chat while I'm discussing, so it's very authentic. I keep seeing the like non-cirrhotic portal hypertension pop up. And I think, I find that the terminology a little bit confusing, but I think from a standpoint of like how the traditional non-cirrhotic portal hypertension presents, this isn't that. Typically patients present with GI bleeding as their sentinel issue, as well as pancytopenia, which this patient doesn't have. But what is really interesting, and this kind of comes from one of the other discussions that Robbie and Reza had recently, as far as like, where does ascites come from? And ascites is from the liver cells crying into the liver. And the way they know this is that they gave dogs cirrhosis from, I think, like ligating one of their vessels. And basically they put like a plastic bag on their livers, and that's where all the ascites drain into. So we know that the acidic fluid comes from the sinusoid. So really, there you can localize portal hypertension to post-sinusoid, intrasinusoid, and like pre-sinusoid. And really, we would have to be invoking sort of a pre-sinusoidal process, because there is no ascites here. We saw nothing on the scan. Maybe we could have missed like a small amount, but really we're not seeing that there. So really the possibilities of what causes pre-sinusoidal disease is sort of like the small bile duct disease, which again, we're not seeing prominent biliary abnormalities like in the labs to suggest that's what's going on. We didn't see anything on the imaging, not to say that we couldn't miss it and we could get, a more advanced imaging to try to make progress with that. Schistosomiasis is on the list, more idiopathic disease, sarcoidosis, and then the other ones would be like primary a vascular issue. And then, we're saying that this is clot in the portal, we're in the portal vein, but what is the nature of the clot? Is it actually thrombus, or is it something else? And so I always like to ask that question just to make sure we're not missing the potential for a malignant clot or something like that. But that's where I'm at. I know we're low on time, so Mukund, take us away before we keep rambling on.
Sounds good. Yeah, we'll be careful about time. We'll give you this last little bit of information. Well, it's not little, but this is a really complicated case. 2 times blood cultures were negative at 48 hours. Hepatitis and HIV were negative. And we did end up getting some extra imaging. GI got on board. I think everyone was on the same page as you, treating for infection, but worried that this thrombus was actually tumor thrombus. The way we were taught to think about thrombus is this bland thrombus, and if so, is it infected or not, and then is it tumor thrombus? In this case, we went down to radiology, talked to the radiologists, and they all were concerned about tumor thrombus, and they thought that the hepatic hypodensities were more likely to be malignant rather than ischemic or infectious. So GI got on board. An MRCP was done, which showed an interval decrease in the common bile duct dilation to 1 centimeter from 1.4, but otherwise similar read. A colonoscopy was done, which showed 1 rectal polyp, but otherwise completely normal, and they actually used a special scope to look at the ampulla of Vater, and they didn't find anything there either. A CEA, an AFP, and a CA 19-9 were also sent from the serum, and all were normal. So at this point, hematology gets involved with this malignancy hypothesis a little lower on the differential after a thorough rule out. And they send iron studies, which is remarkable for a mixed iron deficiency and iron anemia of chronic disease picture. An LDH of 208, which is normal, a haptoglobin of 170, which is normal, and a smear that does not have schistocytes. JAK2 mutation panel is sent and pending. And just so that you can contextualize this, it's now been several days since admission. She's been on ceftriaxone and metronidazole the whole time, and she is remarkably clinically improved, completely afebrile, and a white blood cell count is now 9.2. That's all the information I have for you before the final diagnosis.
Wow, incredible. So yeah, I think I really like that you made this, sort of stress the multidisciplinary aspect of this case. And yeah, this is not a case that we'd be able to solve alone. At least for me, there's no way I could do it on my own. So leaning on your GI colleagues and your hematology colleagues, and this is really wonderful. So I think there's some devastating news in the sense that there's definitely a high probability and concern for malignancy, but some really positive news in the sense that the patient is markedly better than before, and is making progress clinically. It sounds like maybe they defervesced, the white count has definitely come down. So what the heck happened? And so I think this is real life, in the sense that most likely this patient had a chronic disease that wasn't recognized, or patient had not been able to seek care for various reasons. And then there was an acute complication related to it. And we happen to be meeting the patient where both of those things are happening simultaneously. And it definitely clouds the picture of what's happening. But this is the beauty of this space and sort of being diagnosticians and understanding that there is acute on chronic possibility when we're forming a differential diagnosis, and that the time course and clarifying the time course really should take up a large proportion of our energy when we're trying to solve a case. And so when I think through, the acute on chronic, what's possible, I'd say, well, the patient received antibiotics and they improved. So if we're concerned that there is a cancer there, or a thrombus there, and whatever the nature of the clot is, there is an infectious component to that, and we have fixed that aspect, and so now the patient is better. I mean, I think that's probably the leading hypothesis here right now. And the diagnosis of whatever the underlying chronic issue is, comes secondary to that. So that's where my headspace is right now. I like that they sent the JAK2 mutation. We kind of brought up the potential of the why portal vein thrombi happen, and it is one of those conditions that can definitely do that. My reasoning aspect of how I got there, I was perseverating on the white blood cell count and talking about the differential, and so if the JAK2 comes back positive, then I guess some would argue that I got to the right answer, so that was the thing to do. But I really don't think we're in that space right now. So what I'd say is, it sounds like the patient had a super affected clot, whatever the nature of that clot is. They improved, and now it's trying to understand what the nature of the clot is and what the nature of the lesions in the liver are. And so maybe if the patient is so dramatically improved, we repeat their liver imaging after some time and see if there's been improvement in the findings. But I think still I'd be pursuing the malignant aspect of this. So Alec, what are your final thoughts?
No, excellent thoughts. And so very, very thorough workup by Mukund, his team, and all the consultants. And those tumor markers are imperfect. And I think one thing that we could think about too is, like, could this just be cholangiocarcinoma as well? This is something I was thinking about. And then the biliary ductal dilatation that was there and then sort of regressed to still a little bit above normal. Could that have just been related to underlying cholangitis that was better after the antibiotics? And then it sounds like probably this is pylophlebitis, but probably from a malignant thrombus that got better with the antibiotics. And I think we still don't really understand what triggered the thrombus to form in the first place, because she's had the thrombus for a long time. And it seems like, I don't know if it was the venous pressure from the portal vein that led to a higher likelihood to translocate bacteria in the gut. And maybe she ended up getting infected from that way and then improved with antibiotics. But I think going back to what led to all this, and either there's something local that's inflammatory in that area, likely malignancy, that's triggering this, but none of the imaging or age-appropriate cancer screening has revealed that. So if that's not the case, either it's a cancer that we haven't yet found, and sometimes cholangio, at least in my clinical experience, can be difficult to diagnose until you get tissue. So I think if it's still a little bit unclear, we could discuss whether or not maybe biopsying one of those hepatic lesions would be worthwhile, unless there's something else that's we're able to do locally. And then, I'm sort of thinking about the heme aspect of this case. And, while the patient had an acute pyogenic infection, could the differential have changed and become more neutrophilic predominant? By the time you treat the infection, maybe there is a more lymphocytic component to this. Maybe they had underlying CLL. Or, for example, perhaps the platelets were lower than they are now, and the patient had relative thrombocytopenia, and then they went up. And could this, Robbie, and I'm blanking on all of this, but he has the CBC, and he talks about the white blood cells and the hemoglobin and the platelets, and as far as myeloproliferative neoplasms and all being up, and how they're JAK2 related and how they increase your risk for thrombosis, and certainly portal vein thrombosis would be one of those. So I think if it's JAK2 positive, we could say the patient had a clot for a long time, had changes, and they had it super infected. But I still can't get out of the back of my head with the interpretation from the radiologist, and then those hepatic hypodensities thought to be metastases, that we are still missing something. Yeah, I'm just very interested to see where this goes. I'm very glad to know that she was feeling better after the antibiotics, but for the purposes of time, Mukund, please take us away.
Absolutely. So unfortunately, the bad news is that we don't have a diagnosis. But I will walk you briefly through what our thought process was here. So interestingly, going back to the CT with signs of possible tumor thrombus versus maybe blend thrombus and hepatic hypodensities read by a radiologist as maybe a metastasis. I think it's worth noting, and this is a learning point for me in this case, that the radiologist didn't comment on that in his official read. It was something that we learned from him just through informal conversation. And fascinatingly, once we got the MRCP, went back down to radiology, spoke to a different radiologist who read the same hepatic hypodensities as more likely hepatic infarction related to the burden of portal venous thrombosis. So, a fascinating case overall, even on that front. And that at that point was when hematology got involved. Cancer screening had been done, a new image had been acquired, the hepatic lesions had been read as maybe more likely now ischemic than malignant. And hematology came on board with a differential, to be explicit, of antiphospholipid syndrome, thought to be so unlikely that they didn't even send the APLS serologies, versus paroxysmal nocturnal hemoglobinuria, which is why the hemolysis workup was sent and was negative, versus myeloproliferative disease, and the JAK2 mutation panel is pending. The common bile duct obstruction is another interesting detail here. And I think when we got involved, the infectious diseases team had the hypothesis that maybe this was all just an episode of cholangitis, common bile duct obstruction, a while ago that resolved by itself, but in that setting of transient inflammation caused the formation of portal venous thrombus that became secondarily superinfected. Ultimately, we don't have an answer, like you all said, but we had to treat this as pilophlebitis. So a really unique entity, septic portal venous thrombus, is known as pilophlebitis, sometimes called abdominal Lemire syndrome. And of course, enteric gram-negative pathogens must be covered, but so must anaerobic fastidious species like Fusobacterium, specifically Fusobacterium nucleatum over necrophorum, which is found in the IJ, and Bacteroides species, which are so hard to grow on blood cultures that unlikely to be isolated just off the 2 blood cultures that we got. Maybe would need to send 5, 6 or more, and there's a tube shortage at our hospital, so we weren't able to do that. Ultimately, patient felt better, goals of care conversation was had. The next diagnostic step would have been biopsy of a hepatic lesion, but that wasn't in her goals of care. So she was diagnosed with pilophlebitis, and she was sent home on 4 weeks of Augmentin.
Wow, Mukund, what an amazing case. Thank you so much for sharing it. Even with the uncertainty, this is medicine. This is what we do every day. And I think it was a really rich way to discuss a lot of these different findings, layering the past history, the febrile syndrome, the acute and chronic component of it, and then sort of really getting uncomfortable with radiology and going back to them and the interpretation, and just updating your problem representation at all times. And I think I just really enjoyed it. And Austin, I'd love to hear your reflections, and then we can get to the teaching points and whatnot. I'll have to step away to take my son to the doctor, but thanks to you again to everybody, Patricia, Nishis, Mukund, Austin. I really enjoyed this, and I can't wait to listen again.
Yeah, thanks so much, and best of luck at the doctor. And yeah, Mukund, what a wonderful case. Thanks so much for sharing, and the way you outlined it. I think you really set Alec and I up to have a really meaningful discussion as far as the clinical reasoning aspect of this. So thanks so much. My reflections are that medicine is hard and it's a team sport. So I think that was a really great example today. If I do a little bit of a cognitive autopsy and go back to the initial episode of nausea, vomiting, abdominal pain, and then link in the the clot history as well as the possibility of infarcts, then it does make me wonder about if this was a manifestation of mesenteric ischemia from the venous side as opposed to the arterial side. That might be taking the hypothesis a little bit too far, but it did cross my mind earlier. And then once we got the idea that this would be potentially could be infarction, then it did cross my mind again. So I wanted to bring that up. And if anyone has any more insight into that in the chat, just let me know. And then the other thing is like, yeah, would I expect infarcts to look in this way? No, like not at all. Like this wasn't on my radar or my illness script for how infarction looks. And Andrew is here today and he's taught us a lot about pulmonary infarction, and that sort of changed my illness script for it. And so maybe I need to update how infarction manifests in other organs too. And yes, so much learning, so much to read about and reflect on. And Mukunda, I imagine there depending on this patient's goals of care, they're planning to like repeat the imaging if the patient's able to follow up in the outpatient setting and then see if there's been improvements or change in what the scan looks like. Okay, yeah, he's raising his thumbs up. So yeah, I think that's a very reasonable approach. Like the patient is doing better. It is a non-invasive way to evaluate what's going on, and if it's completely improved, then I think we have a diagnosis. So really awesome. So I think whoever's doing teaching points, I think it's Patricia, if I'm not wrong, then take it away.
Thank you so much, Alex and Austin, for this great discussion. We had a lot of takeaway. Thank you so much, Morgan, for presenting this case. So we learn about abdominal symptom. We usually have the mnemonic to think about vascular inflammation, perforation, obstruction, causes, and we need to consider the time course, acute versus acute and chronic. So we were mostly focused on the inflammation bucket with the fever, night sweat, asthenia, malaise. And in the inflammation bucket, we have possible cause of infection, malignancy, autoimmune, or endocrinopathy. So with on this case, we thought about management with fluid, antibiotic, look for endemic source of infection like TB, hepatitis, and also look for possible malignancy like do a CT of the chest or in the colon. We had a thought about GERD that beside the general presentation of GERD can also present with isolated nausea, cough, non-specific abdominal symptom. So in the setting of primary care, we need to look out for it. And also that mirtazapine is a medication that we usually use to stimulate appetite, and that we also use for depression. So we also have a thought about white blood cell projection in a lab. So when we have neutrophilic predominance, we need to think about bacterial, fungal infection, or paraneoplastic syndrome. When we have monocytic predominance, we can think about immunosuppression. Lymphocytic predominance, we need to think about lymphoma, or eosinophilia, we look for respiratory symptom, rash, allergic reaction. In this case, we had alkalosis, and in the setting of alkalosis, we need to think about volume contraction. We look for chloral depression. It can also be caused by vomiting, renal tubule dysfunction, CKD. In those cases, we look at the GFR, or hyperaldosteronism, which we can look for the potassium value. If it's low, we can further our diagnostic toward hyperaldosteronism. In case of reactive thrombocytosis, the different causes are spleen issue, iron deficiency, autoimmune disease, infection, or solid cancer. In this case, we had a CT which showed numerous hypodensity of the liver, and it can be a clue for malignancy, infection, infarct, thrombosis of the portal vein or abscess. We learned that the portal vein supplies approximately 70% of the liver, and portal vein hypertension, in case of a non-cirrhotic portal vein hypertension, which can be manifested by GI bleed, pancytopenia, ascites, we need to think of possible cause like infection, like schistomiasis, or pancreatic lesion. Also, another way to see portal vein hypotension, non-cirrhotic portal vein hypertension, is to divide it in post versus intra and pre-sinusoid process. Like an example of pre-sinusoid process disease, we look at bile duct defect, sarcoidosis, or vascular issue. So thank you for the discussion for having me.
Oh, great job. Thank you so much. So many teaching points you're able to capture. And I think you always make Alec and I look better than we actually are. So I appreciate it. Well, again, thank you so much, everyone. Makun for presenting, Vinicius for scribing, everyone who joined today, and the rich discussion that happened in the chat. I was just looking through it, and so many awesome pearls. And you guys were, I think, way ahead of us. So we're in there. So thanks for another wonderful VMR. And please don't forget, there's a subspecialty VMR tonight with some amazing people, including a CP Solvers OG, Dr. Dan Minter, who is an incredible reasoner, educator, and is now an attending in infectious disease. And so it's definitely one that you don't want to miss. So have a good day, everyone. Bye-bye.